Well, welcome everyone, and thank you for joining us for our first session. I'm Natalie Stubbs. I'm with the Association for Utah Community Health, and we partnered with the NEPQR team to help host these trainings. So I'm going to turn it over to Larry to introduce the speakers for today.
All right. Hey, welcome everybody. We've got a good group today. Have a really exciting topic, something that's probably near and dear to all of us, which is dementia. We all know somebody. Matter of fact, we're going to ask who knows somebody here in just a minute. This is the first of a three-part series on dementia. Today, we're lucky to have Nancy Allen, and I'll introduce her here in just a minute, but it's kind of the nursing role in assessing patients with dementia. Next week on the 16th at the same time, we'll be coming back. We have created a series of 3 videos that are actually a full nurse assessment. And we also have all of the tools. And we're also going to bring back Haley Haffey, who's presented for us before on narrative medicine. And part of this is really important. As you're assessing, you also need to be listening in all those nonverbal clues and cues about the family and the patient that you're picking up. And so it'll be a combination of, here's an introduction to some of the tools, the videos that we have, and the tools that support it. And then we'll do a little bit of narrative medicine. So we'll watch a little clips of the videos and break into groups. And then the 23rd, the last week, we will meet again. And we're bringing in some community resources, AARP, the Alzheimer's Association, the AAA, the state. And the question that often comes up is, so I have a diagnosis of dementia with one of my patients, now what? And so we want to bring some resources to bear. With that, I'd like to introduce Nancy Allen as our guest speaker today. Nancy Allen, she's an associate professor at the College of Nursing at the University of Utah. She's also a nurse practitioner. She has worked in the Cognitive Disorders Clinic at the University of Utah, where she gained a lot of experience working with older adults with memory problems. She's very passionate, and I can attest to that. She is very passionate about the role of nurses can have in assessing and caring for older adults and their families when they're experiencing memory challenges. This is an open meeting today. It's a little bit different format. I'm going to be monitoring the chat. If you have any questions that come up, you can feel free to just kind of come off mute and ask Nancy when we discuss that, and she's very comfortable with that. If you feel a little bit shy, I'm going to be monitoring the chat function, and you can come in that way and you'll let me interrupt her. So open discussion today on dementia and the nurse's role. With that, I'd like to turn it over to Nancy.
Hi, everyone. I'm so excited to be here to talk to you all about, older adults with memory problems. And, if you guys want to turn your cameras on, that would be great, because I kind of planned this as an interactive discussion versus kind of a PowerPoint, get up there and talk through the slides. I think that this is a topic that really, needs discussion. And so, I think just to kick it off and kind of break the ice a little bit, do you guys all see down at the bottom on the right, it's of your Zoom screen, it says reactions. If you click on that, you can raise your hand, and I'm going to just take a quick poll. How many of you know somebody who has memory problems or dementia? So go down to that reactions, and then kind of like hold up your hand if you, I'm going to do a thumbs up because I like thumbs up. Okay, so let me just peruse the screens here. Let's see how many people have their hands up that they have somebody, that they know somebody in their life that has dementia. Okay, not too many people that don't have their cameras on have responded to that question. But then again, maybe they don't have anybody in their life. Well, let's go ahead and let's talk about, okay, I got to put my hand down now. I think my hand is down. Where am I at on the screen? There's so many people logging on. It's like I'm moving all around. At any rate, so there's a real art to evaluating and assessing somebody who's got dementia. And there's several steps that are really important. One of the things that we're going to be working on through this series is, how do you, as a nurse, really work to that full scope of your license? And, oh yes, you can go to lower your hand. And kind of set your practice up so that you can do the initial assessment. That's what I'm going to focus on today, is that initial assessment of these, older adults that are having some changes in their memory. And so I'm going to kind of take you through, what that assessment could look like. And, then we'll keep working on this, building on it throughout the next couple of, talks that we have, webinars. And hopefully you'll start to say, you know what, I could do this. And I think it'd be a great benefit to the providers in the clinic if I was doing this. So as we know, many times, nurses can develop an expertise in a certain area, and they bring a whole different dimension to patient care. So this is an area where there's a huge need. And this is an area where, nurses can really shine. And it's just so needed. So that's why I'm so excited and passionate about this. Once again, Larry told everybody that, I worked in the cognitive disorders clinic at the University of Utah. And in that clinic, I could tell you that I saw, and this may or may not surprise people, referrals from neurology clinics with, not very good workup and evaluations of a patient with dementia, because that's just not what they did. And so it's really, how do I say this? There's just not enough people that are really engaged in doing this type of work. They just are kind of like, yeah, I don't want to do that. And there's a lot of reasons why people don't want to evaluate somebody with memory problems, because they won't know what to do next. But we're going to talk about that, like Larry said. The problem with just saying this is not what I do, and oh well, it's really hurting patients. It's hurting families. The other barriers that I hear people talk about is, I not only will I not know what to do, but I don't think that there's much that can be done for patients with dementia. And just saying that kind of breaks my heart, because I just look at how much we can do for these patients. And so I want to get you kind of fired up thinking about all that nurses can do for these patients. But then I want to come back and focus on how do you help the providers and develop that expertise. So when people say there's nothing that can be done for dementia, what they're talking about is that cure-focused type of care that can be provided. So I can cure somebody's dementia. Well, we don't have a lot of cures out there. That doesn't mean that that's not coming, because science is always changing. But what we do have is a lot of care and education that can be provided to these patients and their families. And so that's critically important. But the first thing you have to do in this whole, matter of fact, I'm just going to talk about that. I'm just going to expand on that a little bit more, that care piece. What can you do? Just because I want to paint that picture and kind of say, okay, this is the road, the journey we're on, and how do we go there? So, once a patient's been assessed, then they get evaluated. There'll be different tests that will be ordered. And then it becomes that care piece. And the things that we can do is what we call proactive care. And that is really anticipating the problems before they arise and making sure that you've got things in order for that patient and family. And those things, they consist of, for example, medications. Oftentimes people don't know what the Beers list is. And that's a list of medications that you shouldn't take when you have memory problems or dementia. And so then they'll be prescribed medications that actually make it worse. So like somebody will have anxiety, for example, they got memory problems and anxiety, right? And all of a sudden, you know, somebody's been prescribing Ativan to them. Well, Ativan, although it's, you know, for anxiety, but if you look at the Beers list, it's contraindicated. And the reason it's contraindicated because it actually makes their anxiety worse if the cause is from memory problems. So that's one of the things that, you know, is part of that care. The other things are things like, you know, making sure that the patient and the family understand, you know, if all of a sudden their loved one gets confused after they've received their diagnosis, you've got to get on a hunt. You've got to figure out, is this due to dehydration? Is this due to an infection? Could it be a tooth infection? Could it be a urinary tract infection? And lo and behold, you know, you go on that, and if families are prepared and they know, then they can go get that taken care of quickly, and then they have their loved one back, you know, and they're not like at death's door. There's so many things in that care piece that are important to know when you're taking care of these patients. And so that's what I just wanted to paint, that picture that yes, there's a lot we can do for patients and their families when there's a diagnosis of cognitive disorders or dementia. And I'm going to just give an umbrella statement here. So many of you probably know, and some of you don't, because I know I didn't, but when I went into cognitive disorders, I didn't realize that dementia was this umbrella term. I had no idea, to be quite honest. And so if that's an umbrella term, what is dementia? You know, okay, so dementia, there's actually over 100 different causes of dementia. And that's why it's really difficult to evaluate these patients unless you have a good history and unless you really have a good evaluation to really, because the thing is not all dementias are alike. There's some dementias that, you know, they're called dementias, but actually it's like a frontal temporal lobe dementia. And the memory isn't so bad, but boy, is their behavior, you know, really challenging. So you know, this is why having this good history is critically important in helping that provider really figure out what's going on. So we're going to talk more about that. And I am going to start, I think, by taking you through just the beginnings of this case study that we built this video around that you're going to kind of dissect pieces of next week. And then I'll take you and we're going to pretend like we're in that exam room, okay? And we're starting to ask these questions. And once again, if you guys want to turn your cameras on, I want this to be interactive. I want to see you guys, you know, asking questions and really getting involved in this and clarifying things when I'm not clear, okay? All right, here we go. Let's go with this scenario really fast. Well, I'm not going to be fast, sorry. Let's go with this scenario. I won't read too long. Okay, but here it is. The son calls the clinic. He's calling you and he says, I have concerns about my father. And his name's Mr. Kent. And he's a patient that's well known to you. And he lives in his own house, and this is located in a rural community. They have received reports from the neighbors that he's been wandering around and getting lost. Okay, you know, right now you got a problem, right? Oh boy, right? Okay, this is not good. This is really not good. He lives alone and he's wandering and getting lost. Additionally, he's made some disturbing phone calls to his son about people being in the house and how much this has been scaring him. So just to kind of point this out, it's, you know, there's hallucinations and delusions. And a lot of times in patients with memory challenges, problems, dementia, they will have these, hallucinations. The key question is, are they scary? Okay, because sometimes there's not a lot that can be done when they have hallucinations. But if there are hallucinations, then something probably should be done. And, I probably won't get into the treatment aspect of this, but just note that that's an important thing. It's scaring him. Okay, so write that down when you get this call. And the son put up cameras around the house, but he hasn't seen any strange people coming or going. Yet he did find that his father was wandering around in the middle of the night within the house. And there's a lot of reasons why people with dementia have these, wanderings in the middle of the night. And there's a lot of strategies, and that goes into that care and treatment piece, of how you can change the lighting and different routines you can put in place, and eliminating coffee, a bunch of coffee. A lot of these people drink a ton of coffee and then they're up all night, but it is part of the disease process. But at any rate, there was nobody wandering around. Okay. So from the medical record, you note that Mr. Kent is an 85-year-old with a history of type 2 diabetes. So just to give you a fact, people who have type 2 diabetes are 73% more likely to develop dementia. And that breakdown is 56% will have Alzheimer's disease. And I think it's like 123%. It's either 123 or 126% will have a vascular dementia. And if you think about diabetes, and that's why I said there's over 100 different causes of dementia, right? I always get my antennas up when I see a lot of vascular risk factors. And we're going to see some here. But if you think about diabetes, that high blood sugar is just like having sand going through your blood vessels, and it kind of rips it up a little bit and causes vascular inflammation. And you got the same blood vessels in your brain as you do in your kidneys. And, our diabetes patients can have nephropathy, kidney damage, and they can have neuropathy, which is the nerve damage, and they can have retinopathy, which is the eye damage. Well, they also can get it in their brain. So that's a vascular dementia. It's a different diagnosis than an Alzheimer's disease. But once again, they're also susceptible. So already, this patient's got diabetes. I'm starting to think, ding, 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 ding. Okay, that's a risk factor. Stage 3 kidney disease. Okay, those same blood vessels in the kidneys are up in the brain, right? Okay, and he's overweight. And that's another risk factor for having dementia. He's had a few falls in the last year. It's so common in patients with dementia. And his A1C has been steadily increasing from 7.5% to 9.5%. Whoa, what a change, right? Now, I will argue with anybody who says, doesn't matter if they have a high A1C when they're older, it doesn't matter at all. Well, did you know that having those high blood sugars is shown to be a big cause of dementia? So, and probably the other thing a lot of people don't know is that having a high blood sugar, having a high A1C, doesn't prevent them from having hypoglycemia. And it is not, it's not a good strategy. There are much better strategies than having their A1C climbing up to 9.5%. And then they suffer from hyperglycemia, which causes dehydration. That's a big thing in older adults, especially with memory problems. Okay, so at any rate, the reason why, and this is what you need to be suspecting in this case study, that he's going from a 7.5 to a 9.5% is, this is where you go ding, 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 ding. He's not remembering to take his medication, And so if you don't remember to take your medication, you can be real high. Now, if a patient is on glucose lowering agents, then, like a sulfonylurea, insulin, they may double dose themselves, and they do. They end up in the ICUs in the hospital with a severe life-threatening hypoglycemia reaction, and they'll have seizures. So another time when you got to be, oh my goodness, they were just admitted to the hospital and they had a seizure from a low. Wonder what's going on. Well, be thinking in an older adult, that might be their memory. Okay, so this patient also has a history of strokes, hypertension, and aneurysm. Oh, no, excuse me. This patient has no history of strokes. I was like, oh my God, we really made this guy sick. Okay, so the patient has no history of strokes, hypertension, aneurysm, psychiatric history, neurological disorders such as seizures, problems with alcohol, or known exposures to lead, mercury, or arsenic. So the reason that I point those things out is because those should really be part of your assessment. Has this patient had a stroke in the past? Okay, once again, that's a vascular complication, more likely to develop a dementia. If they've had high blood pressure, more likely to develop dementia. And I'm just going to give you another factoid about this. The SPRINT MIND trial. So the SPRINT trial was a hypertension trial, and the SPRINT MIND trial showed that if you keep the blood pressure at 120/80, people are less likely to go on to develop dementia. So, just knowing if somebody's had a long history of having blood pressure that's been high and not well controlled, another risk factor. Aneurysms, same thing, another risk factor for developing dementia. And if they've had a psychiatric history, that's important to really understand, because that's part of what's got to be teased out in these patients. Is this because they've had bipolar lifelong? Because you don't diagnose bipolar or schizophrenia at the age of 70, that's usually diagnosed much sooner, right? But let's just say that somebody has had bipolar disease for a long time, and then all of a sudden, they're coming in with memory problems. Well, the first thing, if they've got that kind of a psychiatric history, then you've got to figure out, have they been taking their psychiatric medications, or, is this really something like, the dementia? So oftentimes, if you do get that psychiatric history, then you're going to want to make sure that they get evaluated for their, behavioral health, mental health condition, and make sure that's stable before you have a real in-depth cognitive evaluation. Okay, so that's why that's key. And do they have other neurological disorders? So do they have a history of seizures? And I can remember this guy, he was young, he was only 61, but let me tell you, in the cognitive disorders clinic, I saw lots of people who you wouldn't think should be coming in, right? But he was 61, and, it was disturbing, the history I was getting from his wife. Like, he could barely complete sentences, and he was very confused. He worked as a ranger, was very confused at work. And as, I was listening to the story, she said, and sometimes I'll notice this hand and it'll just be kind of doing this. And then, he's not like talking to me after that. I went, okay, I think that's a problem. And so I said, let's figure out if he's having seizures, and ordered an EEG. And sure enough, he was having a lot of seizures. And the scary part of that was he was driving with all those seizures, and it was terrifying. So before they left, I said, he can't drive. He's not allowed to drive until we sort through this. But anyway, that was a striking case. But that's all that part of that, really listening and evaluating. And if they've got alcohol's another really, it can be another cause of dementia, and it's a special kind of dementia. And oftentimes it's treated differently. So that's, when they need to have some vitamin B12. And then known exposures to lead, mercury, or arsenic. So like, let's say that they worked at, what is that big mine? The Kennecott mine. and, they had a bunch of exposure over their time working in there. That might be another thing. And so that would be kind of one of those, we might have to check, the urine or blood for heavy metals. But anyway, so that's why I kind of bring up some of those different things in that history. So what you're going to do as the nurse is you're going to say, I don't know, the son's probably called Mr. Kent Jr. I'm just making it up because it's a made up case study. But basically, could you have Mr. Kent come into clinic, and I'm going to do an initial assessment, and bring his medications with us, because that is one of those things that can cause cognitive problems as well. So, and then you've got on file kind of this set of questions, and this is what I'd kind of encourage, is that you've got kind of this evaluation put together so that when they come in, you're prepared. Now, I'm going to tell you that the most successful, because these patients can be challenging, although I just think they're wonderful. The most important thing is that you do make that connection with them when they come in. So don't talk to the son. I mean, we've all been taught that, right? Don't talk to the family members, talk to the patient, right? And that can become really challenging when somebody's got memory problems. So I highly recommend that you position yourself so that you are, close to them so that they can hear you, because there's a lot of hearing loss as we age. And actually, are you ready for this factoid? This is one of those amazing factoids, is that 40% of if you looked at a pie chart and it has all the different causes of dementia, 40% of that pie chart is because of hearing loss. So this is like, okay, run out everyone and get their hearing aids right now, right? Okay, so any rate, but you want to position yourself so that you can really talk to him, have him hear, have him engaged with you, because it's hard for them to keep their attention if they're suffering from any type of a dementia. And so let's go ahead and let's ask some of these questions. And I'm going to say, Mr. Kent, have you had any difficulty remembering something that you've had to learn lately? So, and oftentimes they'll look at you like, what are you talking about? I haven't been in school or anything. You could say, well, have you gotten a new cell phone, a new TV, a new appliance in your house? Have you, gone to any church activities where you've had to memorize something, and then oftentimes they'll say, yeah, and I couldn't do it. It was really hard. I can't do it. I mean, they can't do it at all. And that is that's a piece of this evaluation, that if they're having a difficult time learning something, then it's probably some type of a cognitive disorder. But then again, if they're sleep deprived, it could be because of that. So once again, we're on an investigation when we're working these patients up. So at any rate, try to figure out if they're having a hard time learning things. And then another question is, have you been having difficulty remembering important dates or events? And, they kind of look at me. Sometimes this is like a one-sided conversation, and you've got to say, like birthdays, holidays. Did you remember this appointment today? And you can bring up some other things that would be important for them. And then go ahead and write the answer down. And, Mr. Kent, have you been having any problems losing or misplacing things? And now the thing is, if you asked me that question, it would not be good. I'm just going to say, because I lose my keys all the time. So I just have to say that if somebody says to you, yeah, I lose my keys all the time, you better put it in context, because hopefully the family member will say, and they've done that their whole life. Okay. So that's not fair if somebody says that. But if they're losing their glasses, their billfold, their wallet, their, everything and just, can't find it. That's a problem. So go ahead and try and figure that out. So then, have you been having any difficulties with reading or so not to worry, I've lost my driver's license twice. I love that, Brenda. I mean, yeah, I'm not worried yet. Okay, not until you answer the rest of my questions. So the next thing is, have you been having any difficulties with reading or writing? And sometimes people will be like, I'm not having any difficulties with reading or writing, but I can't do any math. So this is just tapping into different areas of the brain, and I'm pointing to this lobe right here, the temporal lobe, because that's where some of those activities can have to be processed. And so, it's an important one. And sometimes if the patient's not certain, I'll just say, here, well, can you read this for me? And I'll just grab, well, we used to have magazines in the office before COVID, but I don't know. Now it's like, I'm not sure what you'll have in there. But have you gotten lost in any familiar surroundings? And this poor gentleman, of course he has. I mean, well, he may not remember. That's another detail. So probably there's a fair number of these patients that have no insight into their memory problems. And so they'll be saying, no, I don't have any of these problems. No, I'm just fine. And the family's going, that's not true. And so then I have to kind of say, okay, wait a minute. I'm going to get Mr. Kent's perspective, and then I'll turn and I'll ask you your perspective. And Mr. Kent, I'm going to ask you to be patient with me, because sometimes our brain actually tricks us a little bit, and we don't remember all the little details. So, but I want you to know I'm going to listen to your perspective, because you realize what the family member just said. That's not true. And all of a sudden you're going to get this fight going on in that room. So it's best to just say, so Mr. Kent, have you been getting lost? No, I haven't been. Okay, well, thank you. Do you mind if I ask your son here that question? And I have not yet had anybody look at me and say no, but I always ask permission. And then, the son says, well, Dad, remember, you did get lost when we went to X, Y, and Z. And he'll be like, yeah, okay, maybe. Okay, so Mr. Kent, have you been seeing things or hearing things that other people are not seeing or hearing? And that's getting at that hallucinations piece. And that's important in the evaluation too. So then you want to ask Mr. Kent's family if they've noticed that he's asking repeated questions. You can't ask him that question. So you really have to turn to the family member. And, families will often say, yeah, like every 10 minutes is the cycle, and so it's kind of like, okay, that's an important piece of information. And also you want to ask if they're having problems handling things on their own, paying their bills. Another key question, because remember I said there's many causes of dementia and you're on this investigation, right? So you have to ask if they've noticed any personality change, because that question's getting at some of those other types of dementias. So that's a key question. And then have you noticed any changes in their hygiene? And you can ask the patient, how often are you taking a bath or a shower? And then the family member may go, yeah, no, they're not doing that. Or they will do it with a lot of prompting. And then ask questions about remembering to take their medications, and ask questions about their driving and if they've had any accidents. And, the other thing I always ask is, and have you ridden in the car with your loved one? Because then they can truly have that insight into, yeah, they just pulled out. I did this with my mom. She was 91. And she just pulled right out in front of something. And I was like, okay, I think it's time to maybe think about this. And is this really safe? All right. So the other thing is you want to get a history of other family members that have had memory problems. And then you want to assess if the family has noticed any restlessness, pacing, agitation, if they've noticed any aggression, physical or verbal outbursts, emotional instability, where they're fine one moment and then they're crying all of a sudden, then they're fine again and then they're crying. And so these, this is kind of like that detective work, like I said. So the next part of the assessment, because on the annual wellness visit, some of you may be familiar with this, you're supposed to ask part of it is a cognitive evaluation, right? Well, just saying to these people, remember I told you a lot of people don't know that they have any problems with their memory. They don't have insight into it. And then a lot of people are really embarrassed if they are having some memory problems. And so you need an objective assessment. And hopefully you guys are familiar with doing a mini cog. But if not, certainly it's not hard to do. It's like just 3 different components to that. But so that kind of gives you like how they're really doing on that. And with a history that's really strong. So the normal cutoff score with the mini cog is like 3. But if you've got a strong history and family feedback that there's something going on, you may want to say a 4. So right in there. And then the next thing is when you make it. Yeah.
Hey, or Nancy, sorry, my fault. We just put a checklist kind of on the chat. If somebody wants to download this, it's available. It's kind of a checklist of all of these types of things, and you can follow along. And we'll make it again available at the end. Just wanted to have a little resource. We probably should have put it up first, but here it is now.
Oh, thanks so much. That's great. So you've kind of documented this at this point in your interview, your assessment kind of. I call it an interview. That's because I do research. Sorry about that. But at any rate, in your assessment, you've kind of got this picture now of some memory problems going on, right? And actually, you've got some behavior stuff going on with him wandering and things like that. But so now you're going to get that objective assessment by conducting a mini cog. And then that's only one piece of the workup. And that is that in order for there to be a diagnosis of dementia, you also have to have a functional abilities questionnaire, or where you can write down that they have these functional abilities that are now impaired. And so, there's different tests out there. And there's one that we used all the time, which is the FAQ, which is the Functional Activities Questionnaire. But certainly you have to document whether they're having functional problems. And that's because in order to make that diagnosis, and you're not going to be making the diagnosis, but you're going to be sending them on to the provider who needs that information to make the diagnosis. They need to know if there's memory and behavior, and if there's functional problems, because to make a diagnosis of dementia, you need both. And so functional problems, let's go through some of them. And I had some of those questions in there. And those are like paying the bills, preparing a meal, driving your car, getting lost. It's their ability to, simple things like heat up a cup of water, keep up with current events, watch a movie and understand what's going on. It's all those functional abilities. And once again, there's many scales out there. And, Larry and some of our future meetings I'm just kind of wetting the whistle here, going to be having some of those different measures available. Now, some of the other things that can cause memory loss. All right. Yep. So Harper, do you want to tell people what you just did?
Or Larry, would you like to talk about it?
Okay.
Probably we'll speak.
I can, I'm actually going to show this at the very end.
Okay.
We have a dementia webpage, and we have some videos that actually show a full assessment. The Nancy actually does an assessment all the way through from start to finish. We've broken it into 3 components. So you can actually use it as a learning tool. And then all of the assessment tools, the anxiety assessment, the functional assessment, are also located there. So you don't have to go looking for them yourself. It's kind of a one-stop shop.
Perfect. So some of the rest of the things that provider is going to need to evaluate this patient, and everything I've talked about are things that a nurse can do. And certainly, just set this up as, I'll do this initial assessment. You can do this. But assess for depression, because depression and anxiety can look just like an Alzheimer's disease. So when you're actually evaluating somebody, you're getting this strong history. You're like, oh man, this patient's definitely got Alzheimer's disease. And then you do that test for depression and anxiety, and it's like, oh, we may have to evaluate this first. So once again, but here's the thing. I want to throw out a caution here to everybody, and that is you don't want to assume all older patients have anxiety and depression, and that's why they've got a memory problem. Because if you do that, you're going to miss all these patients that do have a dementia of some type that really need a different type of treatment. But I also want you to know that, when I've been diagnosing and treating cognitive disorders, if somebody did have a depression, I didn't just go, oh, well, that's the cause of it. You got depression, and then kind of say, out the door you go. I never, ever did that. Because if depression is the cause of their cognitive disorder, then they absolutely need to have that depression evaluated and treated. So once again, and Larry will talk about resources, that needs to happen. So, and we'll go through, because there's the PHQ-2, which is 2 questions, and a test for anxiety. And so, once again, when I'm talking to a patient, these are some of the hard words to come up with why you're doing what you're doing, right? Is you say to the patient, there are many causes of memory problems. And like I keep saying, we're on an investigation. And part of that investigation is, we need to look for a couple of these things like depression and anxiety. So do your best to answer some of these questions. And so the next thing is you're going to order some lab work. And once again, I would recommend that you just have this kind of an order set up to do this stuff. And here's the stuff you've got to look at, okay? You've got to look for infection. So if you're looking for infection, you have to have a CBC, okay? And if you're going to look for anemia, you have to have a CBC. And so those are 2 causes of having a memory problem, and they need to be ruled out. I mean, obviously, in anemia, you get really tired and you don't have that oxygen carrying capacity, and your brain just isn't going to work as well, right? And so that's important. And then a low vitamin B12. I mean, that is so easy to fix, is to just realize that somebody's markedly, got a low vitamin B12 level and needs to be treated. Hypothyroidism is another common cause of memory problems. And once again, if you come back and you find that, it's like, okay, this is good news, right? We can treat this. Electrolyte disturbances. There's all kinds of little things that can go on. I've seen so many low sodium levels, and it's because they're taking hydrochlorothiazide, for example. Kidney and liver test. Is it because they've got kidney disease or liver disease? Is it because their diabetes is out of control and they've got, like memory problems because of that? So those are the lab work. That's just a standard, evaluation that you should get. Now, some of the other things that you should be on the hunt for is, do they have sleep apnea? you know? And I have to tell you that if somebody has severe sleep apnea, usually about 3 months after they're on treatment, they start to get their memory back. And it's another one of those, yahoo, we got something treatable here in terms of, reversing this. You want to assess for hearing loss. And once again, if your brain's not being stimulated by all that auditory information, it's kind of not going to work as well. And so that has to be treated. You want to assess for incontinence. And I should put on that list of blood work, if you have any type of a history that they may have, urinary tract infection, go for that. And you can certainly add that to your list. And then you want to assess for social isolation. And that can kind of go along with depression. So the worst things for a patient that's having memory problems is to be on their own. Mr. Kent is on his own. And, they're just, they're hard of hearing, and they just can't, process the stimuli because it's not there, right? That's so bad for your brain. So the things that we do recommend, just so you know, so we go down the road a little further, is we recommend at least 30 minutes of physical activity every day. We recommend at least 7 hours of sleep. We recommend the DASH diet or the Mediterranean diet. I'm just sitting here trying to think of this checklist I used to have, because that's not what I'm here to talk about today, but there's a lot of things. But the social isolation, we recommend that they have at least 2 to 3 interactions a week with somebody that's not their family members. And so that it's stimulating. And then certainly daily, and the more stimulation you can get, the better. So with that, I think I'm gonna pause, and I'm gonna I want to listen to you guys. I want to hear your experiences, your questions, and probably the most important thing I want to know is, do you think that you could set up like a standardized assessment and an order set? Because the other things that, probably could be added to that order set is send them off for an MRI, get that blood work, and you can work with your providers on that. So I want to see lots of people chiming in here.
Nancy, can I ask, once you have performed the mini cog, at what point, or what is your cutoff for going beyond that, for example, to a MOCA or a full-blown neurocognitive assessment?
It's a great question. So I know my audience is mostly primary care. You probably know the answer to this, Anne. She's asking me this, but I know.
I'm just testing you. No, I probably do, but it's better to hear it from an expert.
So the state has recommendations, and I think that nowadays, isn't this funny? Now I feel like I'm kind of like old, but nowadays most students are being taught how to do the MOCA, and so that's marvelous. And so if you get an abnormal mini cog, then you need to proceed to a MOCA. Now the reason for that is that the Montreal Cognitive Assessment Test, it is a more comprehensive evaluation, because it has memory, it has attention, it has language, it has executive function, or did I say that already? And like there's just all these different parts that it's delving into, as opposed to just one aspect of that. Now, the MOCA does take a little, well, it does. It just takes longer, okay? I am not going to say, so that's all we used in my practice. So I wasn't even working with the mini cog. And So I'm just going to give you some different scores. So if you know, and you can get training online how to do a MOCA if you just sign up. And the cutoff scores that have been shown in research is that if it's greater than, I hope I remember this right, 26. So the most you can get is 30. And if it's greater than 26, I think, and correct me if I'm wrong on this, is it 26? Okay, greater than 26, then that's considered a normal test. And by God, I can just tell you that I don't remember what date it is, and that's on that test. I never know what date it is, so I can miss that point, right? And then it's still considered normal. So typically, you know, we start to see that mild cognitive impairment. And mild cognitive impairment is when somebody doesn't actually have those functional changes that I was talking about. They just have some changes in their memory. And usually those people are, you know, in the 20s to 26s, could be 18 to 26s when they don't have any functional impairments. But usually that's considered mild dementia if they have functional problems and memory problems, and they've got that score between the 18 and 26. And then it becomes more, you know, it just depends on, you know, the functional status and a whole bunch of other things, kind of where they're at in the moderate stage and severe stage. And I always like people to say, what does the severe stage look like? And it's like, well, you don't recognize a toothbrush for what it's supposed to do. You know, it's kind of, it's in that stage, you know, where it's really severe. And those people usually, you don't want to keep badgering them with having them do a MOCA. It's really a screening test. So it is not a diagnostic test.
Nancy, we've got a couple other questions. Jean, I see, has raised her hand. She's waiting patiently. And then I've got a couple on chat too.
Excellent, go.
Hello, I dropped it in the chat as well. But very often we come across patients who are resistant to using a CPAP for their sleep apnea.
Yep.
What are your strategies to kind of encourage them to use it? It's really difficult.
Yeah, it is really difficult. And I do think, and I guess I'm always hopeful. I'm like one of these people that's like, oh yeah, we're going to have gene therapy pretty soon that's going to treat all these, you know, mental health problems. So I really do think that pretty soon we're going to have, and I know that there is some work being done on, you know, with sleep apnea that's going to be more cutting edge. But for the most part, you know, I mean, people have a choice. They can choose to go on it or not. But what I don't think people realize is how much, you know, memory is one thing. People don't want to lose their memory. So really going after that, you know, topic of, you know, if you're having some memory challenges, this will extremely help it. And yes, there is kind of a period where you have to get used to it. Of course, you know, the other problems with sleep apnea is you can have a heart attack and die, you know. I mean, it's like, this is not to be messed around with. So once again, you know, there's probably a whole body of literature out there on ways to, you know, get people to adhere to sleep apnea machines. I tell them that, you know, if they've tried it before and they hated it, there's newer technologies, there's newer masks, that they really ought to give it a try. And so, yeah, I don't have hard and fast, you have to do this, because that will never work.
Right? I know.
Okay.
All right. Thank you.
Another quick question. This one comes from Jamie. It's, do you have any suggestions on how to support patients who are in denial without family support? How do you balance assessing and providing education without pushing patients away?
Yeah, so that's, and so they don't have family support. Yeah.
Right.
So, and it's not that they're in denial. It's that I just have to reframe this, because it's really important to know that they're not aware. I mean, literally, it's like they're not making stuff up. They're not lying. They're not telling an untruth. And then sometimes family members will jump in and they'll say, they didn't tell that story right. That is totally not correct. That's a merging of like 3 or 4 stories. Well, it's the way their brain put it together. the brain is not working right. So the question is, what do you do when the brain's not working right? So the best thing to do is to, make sure that, because sometimes they'll just get so mad at you. They will get so mad at you because you're questioning them about their memory. So the best thing to do is to really develop that trusting relationship and pick away at it little bit by little bit, and just kind of, it's really important to have feedback of a patient from other members, like friends and family. And so in this situation, we have people that we call them designated care partners, and they agree to allow us to talk to them about their loved one. So that's kind of how you get around it with HIPAA. But, you can always ask the patient if they've got a friend, if family's not involved, and would they be willing to let you talk to their friend? And then you just have them sign the forms. And then sometimes, you can kind of point out different behaviors and say, I'm really concerned. I think it's really important that we, figure out what's going on so that we don't have any problems. And, we don't want to see you in the hospital. Hospitals are bad places. That's what I always say. You don't want to go there. They're bad places. Isn't that terrible coming from a nurse? But they really don't want to go to the hospital. So that's like a motivator. Look at Ann. No, they don't. Any rate, that's some of the strategies that I use.
Well, in the interest of time, I'd like to thank Nancy Allen for her introducing this topic to us. Like I said, this is the first part of 3. Next week, we are actually going to go to the NEPQR webpage, kind of do a little show and tell what's in there. We'll also introduce the videos. There is an actual nursing assessment of a dementia patient that we have. Like I said, it's broken into 3 parts because it does get a little lengthy. And we're going to take bits and pieces of it, introduce the tools that are there so you don't have to go looking for them. And then also do a little bit on narrative medicine, that really important part of listening to the patient and their family so you can find those underlying storylines, things that are really going on, those dynamics. I was going to show that a little bit, but we've run out of time, and that's okay. So we hope to see you all next week. Like I said, we'll go after that. And then the following week after that, the 26th, I do believe, is community resources. Thank you for your time today. Really appreciate it. And if you have any questions or issues, you can reach out to anybody on this team directly and we'll work from there. Nancy, thank you very much.
You're welcome. This was fun. I wish it was a small group discussion, but we live in the age of COVID.
Thank you.
Thank you so much for your attention.